Good afternoon, and thank you for joining us. We're on the road today with Capital City Connection Television with producer Ron Taylor and videographer Kowalski Nelson. We are actually at the Medical AIDS Outreach of Alabama, the clinic on McGee Road here in Montgomery, and our special guests are Michelle Villama, CEO, and Dr. Laurie Dill, the medical director, and later you'll be meeting Will Rutland, who is the Access to Care project manager. And Michelle, by the way, received her master's degree from Troy, so welcome to both of you.
Thank you very much for having us.
Thank you, Carolyn.
Dr. Dill, what is the status of HIV/AIDS today? Do we have a problem with it?
We have a rising problem in the southeast that a lot of people are unaware of, Carolyn. We have the fastest growing rates of new infection of HIV disease in the southeast, including small towns and rural communities. As a matter of fact, Montgomery and a lot of the Black Belt counties in Alabama have 4 times the national rate of new HIV infections per population.
I would think your viewers and listeners would be astonished at that statement.
I think a lot of people are surprised, but the message is everyone should get tested and know their status. It should become a very routine part of primary care for everyone to know their HIV status.
Testing at what age?
Really starting whenever people are sexually active. Starting late teenagers, early 20s, people should start getting tested. And not to forget the elderly, it should go on. The good news for people is that treatment's just really good. People who now get diagnosed as teenagers or early 20s can live into their 60s. It's become a chronic manageable disease for people who do well and stay in treatment. But it's still very deadly for people who don't know they have it or don't stay in treatment.
When you talk about this number of people who have HIV/AIDS, what is the breakdown?
In terms of our patient population, because we cover 26 counties of South Central Alabama, but we see more women than the national average. We see 37% women. We have very high rates of African Americans, probably 75% of our patients. The biggest group in terms of age are young adults. So that includes women of childbearing age, and all pregnant women should be tested because on medication we can drastically reduce the risk that their baby would have HIV, but they need to get tested to know.
Now, Michelle, Medical AIDS Outreach of Alabama is formerly Montgomery AIDS Outreach. How large is your coverage area?
Coverage area is 26 counties, and hence the need for a new moniker. We had expanded services outside of Montgomery County. We have a facility here in Montgomery that provides primary care, and we have a second facility in Dothan. We also have satellite clinics in Selma, Greenville, Troy, and Clayton. And so we had outgrown Montgomery County. And as Dr. Dill was referencing, the actual impact to the southern states as a whole in the southeastern United States is so impacted that our ability to spread the wealth, so to speak, spread those services as far as we can possibly spread them to be able to access those individuals that have limited access to care. Our population that we see here is largely at the poverty level or below. About 65% of the individuals that receive care here are at poverty level or below. And that also makes for difficulties with transportation, accessing care, even going to pick up medications, things of that nature that are going to sustain their health and well-being throughout their lifespan.
And Dr. Dill, when you talk about HIV/AIDS, we're talking about a total of, say, what here in the Alabama area?
In Alabama total, I think there are probably around 17,000 people currently living with HIV or AIDS.
How expensive is that treatment?
The treatment's expensive. We use combination medicines of what we call antiretroviral therapy, and it can cost $10,000 a year per person, but it's very cost effective because it keeps people healthy and out of the hospital. And we see patients whether or not they have insurance, and we help access medications whether or not they have insurance, because there's some federal programs we can access for uninsured people to get them their medicines.
When you think about the national issue of HIV/AIDS, a lot of people wonder where it actually came from. Do they know?
There's some evidence that it came out of Africa from a virus that was in monkeys that changed so that it could invade humans, and probably through hunters of monkeys that had blood exposure.
So it's a retrovirus.
Yeah, they call it a retrovirus, exactly.
Michelle, with this challenge of funding, most of your money comes from where?
Well, we have a good percentage of our funding comes from the federal government through specific programs that are designated for HIV/AIDS populations. But we also are going to see some impact of our state budget as we see it coming down the line, because there are some more local programs that are administered in the state of Alabama. In addition to that, we've had some wonderful success with match grants in the United States in this last year. And in fact, one of them that we do have is a 100% match, or a one-to-one match. And in order for us to achieve that match, we have to be able to solicit donations at the local level. You can imagine, especially in rural Alabama, sometimes there's some difficulty in accessing those dollars. So fundraising can be a challenge, but we're still committed to meeting the needs of individuals that we serve in our coverage area and ensuring that they provide or receive adequate healthcare coverage to sustain their livelihood.
So have you been able to establish partnerships with other organizations? And if so, give us an idea.
Absolutely. In fact, I think partnerships in general for any nonprofit agency are beyond essential at this point. You have to have that community network in order to provide services. We partner with everybody from churches to public state agencies to other nonprofit agencies that help address substance abuse prevention issues, domestic violence, shelters, and just other organizations that address a similar population, because there is some research supported that there are comorbidities. You're going to find domestic violence is going to increase your risk of having contracted HIV. You're going to find a larger percent of people that are substance users or with mental health concerns that are also living with infection.
Dr. Dill, in your work with HIV/AIDS patients, do you find that most of them get HIV/AIDS one certain way or another certain way, or is it just a broad spectrum?
In our patient population, most of it's heterosexually spread.
Now that's a surprise.
That is for a lot of people, but that's true in our patient population. It can be drug use spread, but the majority is heterosexual spread. I'd like to go back to one thing on funding that you said on and accessing medications. We're real concerned at watching the potential state budget cuts coming up, because the federal program to help us get medications for uninsured patients with HIV requires state match money, and we call that ADAP, the AIDS Drugs Assistance Program, and we already have a waiting list of people waiting for AIDS drugs. And if the state health department receives funding cuts that are being talked about currently, that will further really impact our ability to get HIV medications for uninsured patients. So we're really concerned about that. 99.5% of people on waiting list for ADAP, the AIDS Drugs Assistance Programs, are in the Southeast. And those programs get the same federal money, but they get less state money in the Southeast.
It sounds to me like you and Michelle and the staff here at Medical AIDS Outreach of Alabama are trying to keep these patients alive and productive.
Absolutely. People on treatment, if they stay on treatment, take their medications, they can raise their families, they can work, they can go back to school, they can do beautifully, but they need testing, they need treatment, and they need to stay in care. So they need those other things like transportation and access to medications.
You said that it's so important to get early testing. I take it there are no particular signs to look for?
Well, if you get as far as having the signs, you've waited too long, because people who are infected with HIV can have it in their blood for 6 or 8 years before they get sick enough to know they have it. And there are typical signs then of more advanced AIDS, of weight loss and night sweats and fevers. But again, if you're waiting until you have symptoms, you're waiting too long. People should get routine testing as part of their primary medical care.
And how long does it take HIV to morph into full-blown AIDS?
It varies in different people, but it can take 6 to 8 years.
So there's your
average.
timeline.
Mm-hmm.
And I think, too, when you're talking about testing, I think a lot of people may have a misconception about how difficult or how easy it is to get tested. I mean, we have rapid testing now that can be done through an oral swab, and it takes 20 minutes to get an initial confirmation or to find the results.
So just take a swab from your mouth and that's it.
And we do free HIV testing. So a swab from your mouth, no needles, you can get results in 20 minutes, you can get it for free. So,
how do your viewers and listeners find out more?
Our website, for one, maoi.org, or they can call us, and I believe you have our phone number there at 334-280-3349 is our main number, and they can call there for information from any of our sites.
Okay, give that number one more time.
Oh yes, it's 334-280-3349. We also have an education and outreach department who would be glad to go out and do programs in the community to let people have more information.
Okay. And as I understand it, you are also on Facebook.
We are on Facebook.
Absolutely.
Well, I think at this time we need to meet Will Rutland because he has a special machine to show us.
Yes, as part of our outreach to the rural areas, we have been delighted to get a grant from AIDS United to set up telemedicine sites at our rural clinics. So you can have the doctor in one place and the nurse with the patient in another. In our case, it's between Montgomery and Selma, and Will can tell you all about it. We're real excited about it.
We'll find out from Will why that's a necessary machine.
Great, thank you.
Thank you. Will Rutland, thank you for joining us.
It is my pleasure to be here. Thank you for having me.
You are the project manager for Access to Care here at Medical AIDS Outreach of Alabama. What do you do?
That is an excellent question. My primary focus right now is on a new project that we have called our Telemedicine e-health program. And that uses technology to bring the wonderful resources here in Montgomery out to the rural communities in which we see patients.
Is this the machine behind you?
This is in fact the machine, or at least one piece of a series of machines that we use to bring healthcare out to our folks. Montgomery is predominantly linked with our Selma clinic. So we've got this machine here, which as you can see shows full HD video. And then we also have wonderful peripherals like this stethoscope.
How does that work?
That is an excellent question. Through the magic of Bluetooth technology. Now you may be familiar with Bluetooth because of cellular telephones and people who will have Bluetooth earpieces. Bluetooth is a closed frequency radio transmission that allows our nurse in Selma to hold up this stethoscope to the patient's chest and a doctor back here in Montgomery to hear the chest sounds through an identical unit. So our doctor here will have a matching unit to this and put the earpieces in his or her ears and hear it as if they were in the room with the patient in Selma.
So you're actually bringing the medical services to the people in the rural areas thanks to this Polycom.
That's exactly right. That's exactly right. As you may know, Alabama has a paucity of healthcare providers across the full spectrum of healthcare.
Compare it with other states.
Our best projections based on federal numbers are that Alabama has a dearth of about 400 to 500 physicians across all medical specialties. So if you had a perfect ratio of doctors to patients or doctors to population, we'd need about 400 or 500 more doctors here in Alabama.
So the big question is how many of these doctors are qualified to treat HIV/AIDS patients?
Well, the problem's even more dire in HIV/AIDS terms because in Alabama we only have 55 infectious disease docs out of the 31,000 licensed physicians. And then in addition to those 55, we also have 4 American Academy of HIV Medicine credentialed doctors. So a total population of roughly 59 folks who are experts in AIDS HIV care. Now that's a very, very small percentage of our total 31,000 plus physician population. And it's a staggeringly small number in comparison to the full population of Alabama. So there's only about 1 per 75,000 Alabamians one doctor who knows how to deal effectively with HIV/AIDS.
So that statistic alone makes this a very valuable machine.
It
for
does.
patients.
That's exactly right. So when we were faced with that statistic, and we said, here we have this growing population, as you may have heard, of people living with HIV/AIDS, especially in the rural areas of the state, we had to figure out a way to treat that growing problem with the resources that we have on hand. And one way we figured out to do that is to amplify our reach, or to multiply our effect, through technology. So the unit behind me allows a doctor to literally be in two places at once. Our wonderful doctors here at MAO can see their patients physically in our clinic, come into the office, and then see a patient physically in Selma, just using this unit behind me and with the assistance of a nurse in our Selma clinic.
So that multiplies the number of patients that doctor can treat.
That's exactly right, and it allows us to bring expert care out to these communities that wouldn't otherwise have access to it.
Is this an expensive machine?
That's a good question. In some terms, yes. I mean, Alabama is a state that sees a great deal of poverty. So as compared to the federal poverty line, yes, this is expensive. It's about $20,000 per coupled unit, between $20,000 and $30,000 if you want to put units in both places. And then you have to add some cost for peripherals. So a total cost, if you want to put two places in communication with each other, is about $40,000. That is a lot of money by most people's standards.
Who bought it?
Good question. A number of people is the answer, I think, the most accurate answer I can give. We purchased this equipment through an initiative of the Corporation for National and Community Service, which runs AmeriCorps. You may be familiar with AmeriCorps, and their social innovation program, through a mid-level grantor called AIDS United. So the corporation gave money to AIDS United, and AIDS United had to match that money one for one. And then AIDS United gave money to us, and we had to match that money one for one. So for every federal dollar, there are two private dollars that purchase this equipment. So at the end of the day, it took many hands to lift this ship, but it's worked, and we're thrilled with it so far. It's worked to great results.
Well, we were shown this map. This is so interesting, and it's shocking.
It is.
How many cases of HIV/AIDS are in the southeastern United States.
Yeah, this really is a staggering graphic, and as you can see, the disproportionate representation here, for any viewers, the darker the color here on the map, the higher the incidence rates of HIV/AIDS. So you can see there are large swaths of the country where you have very light yellow or gray, which means very few reported cases at all. But here in the southeastern United States, you can see that we are red trending into dark brown. In fact, a great deal of Alabama and Georgia and Florida, Mississippi, Louisiana are in the darkest categories, which means that we disproportionately show cases of HIV/AIDS. Something interesting to note is this is the southeastern United States here. This is Los Angeles here. This is Chicago, just here in the center of the country. Notice how much darker the southeastern United States is to what is our country's fourth largest city, third or fourth largest city. We really do have this hugely disproportionate representation of HIV/AIDS infections in the Southeast, and it's something that we have to figure out a solution to. And that's why we're using telemedicine, to try and leverage the resources we have on the ground to meet the increasing demand for.
Dr. Dill was giving us a really hopeful picture,
Yes.
and I know that she has been considered a leader in HIV medicine in
She
the
is.
South.
Absolutely.
But let's flip the coin. And
Sure.
if people are not treated, if they don't come to Medical AIDS Outreach of Alabama for help, what's the outlook there?
You know, it really varies, and Dr. Dill may have touched on this, that it's largely determined by each individual's genetics and their own latent resistance to the virus. But our best guesses are that someone who is totally out of care would have a prognosis similar to someone in 1981, when we didn't know about HIV, we didn't know about AIDS, we didn't have the medications, the antiretroviral therapies there to treat. And so it would not be unreasonable to assume a lifespan in keeping with what we saw in the early 80s.
Which was what?
If you had someone come in, the American Medical Journal predicted that someone who presented with HIV/AIDS in 1981 would have a lifespan of 8 to 10 months. Now, of course, if they've come in, they're already at an advanced stage. They know to go in. And of course, it's a big focus of ours to get tested before you present with any symptoms, because the treatment is so effective. But you know, if you presented with full-blown AIDS, your prognosis without treatment is very poor.
So we know that there are about 17,000 who
That's
have been identified with HIV/AIDS in Alabama. Do you have any idea how many have not been diagnosed?
No, we don't, and that's a terrifying, terrifying truth. Because testing is not yet a routine portion of everyone's regular physician visit. You know, everyone's very familiar. You go into the doctor and you have your blood pressure taken. This is just a routine portion of your visit. Now, does that mean that you have a blood pressure problem? No. In fact, in most cases, it doesn't. It's just a good practice to go in and have it tested. If we could raise HIV testing to that level of acceptance, where you just had a routine test, a mouth or gum swab, it would really do something to address the growing problem here in the South, because people would know their status and therefore wouldn't be spreading it unchecked. Presumably, we could get them into care and reduce by nearly 97% their likelihood of transmitting.
Speaking of transmitting, are the usual ways of transmittal still current, meaning blood, body fluids, needles?
That's exactly right. So it really is blood-to-blood contact or body fluid contact. So unprotected sex is one that everyone is familiar with. As you may know, heterosexual sex, unprotected sex, is our #1 precipitate here at MAO.
And that again is a shocking statistic.
It is, it is. It certainly runs contrary to a lot of the preconceptions about HIV/AIDS. Certainly sharing needles or not being careful with needle use. I know a lot of people, not just intravenous drug users, but a lot of people, for instance diabetics, have to use needles on a daily basis, and that's something you need to be very careful with. So needles, sex, those are really the two fountainheads from which we see most of our infections. Everything else is incredibly unlikely.
Well, let's give everyone contact information
Sure.
one more time.
Please. So you can reach us here at MAO either through our Facebook page. So if you have Facebook, we'd love to see you there. We've got a group of fans there on Facebook. We also have a Twitter presence. I believe it's Montgomery AIDS, at Montgomery AIDS on Twitter. You can call into our main switchboard, which is area code 334-280-3349. We always have someone there to answer the phones. And then you can always come by. We're 2900 McGee Road here in Montgomery. We have an education and outreach department. We're always happy to see folks come in.
And as I understand it, the website is maoi.org.
That's exactly right. And thank you for pointing out that there is an I on the end there. So it's Montgomery AIDS Outreach Incorporated.org, MAOI.org.
And I take it one final question. Treatment is confidential?
Treatment is absolutely confidential. So testing results, treatment, all of that is absolutely confidential. You can come in anytime and we'll give you your confidential results to a test or administer care in whatever ways you need.
I take it the Polycom is getting a good workout treating patients.
It is. It's been a huge success. We've been able to expand. You know, one of the things about access to care is not just having the resources out there, but having them available at times when our patients can actually, they have access to those resources. For instance, we used to load up the van with our paper medical charts and our doctor, our phlebotomist, our nurse, and drive down the road to Selma, which is about 100 miles round trip, one day a week to see patients for about 6 hours. And many of our patients live out or near the poverty line, so it's unlikely that they can just take off at any time to go see the doctor at that one, small window where we happen to be in town. The Polycom unit has allowed us to expand our presence from 1 day to 3 days. So now we can really work with our patients to get a more consistent and more effective regimen and pattern of care in there.
And again, you do have an office in Dothan.
We do.
And you have satellite offices in several locations.
That's right. Greenville, Clayton, Troy, Selma, of course. And really, if anybody has questions in any of those areas, they can call into that central number and we will get you to the closest resource to address any concerns that you may have.
Thank you for the update.
Absolutely. I'm thrilled to do it.
We have been talking with Will Rutland. He is the Access to Care Project Manager, and earlier we visited with Michelle Villema, the CEO, and Dr. Lori Dill, the Medical Director of Medical AIDS Outreach of Alabama. We've been on the road with Ron Taylor, producer, and Kowalski Nelson, videographer with Capital City Connection Television. For Troy University Public Radio, I'm Carolyn Hutchison, thanking you for joining us today.